When a biological process as complex as pregnancy snaps under tension, the search for a reason becomes immediate. For many, that search is driven by the physical and emotional weight of repeated loss. Medical data shows that 50 to 60% of early miscarriages result from chromosomal abnormalities. In these cases, the loss is determined by biology, regardless of lifestyle, diet, or stress levels. Chromosomes function as the instruction manuals for human development. You inherit a set of 23 from each parent, creating the 46 manuals required to build and maintain a human life. If an embryo ends up with 45 manuals, or 47, the genetic instructions become unreadable. At this point, the body naturally halts the pregnancy. Seeking answers for these losses often leads into an alphabet soup of medical jargon. As this funnel shows, you are forced to filter through complex acronyms just to reach a clear action plan. You will likely face a choice between tests like Karyotyping, CMA, and NIPT, or to schedule an amniocentesis. Choosing the wrong test out of confusion wastes thousands of dollars and burns weeks of time in agonizing suspense, often yielding results that offer no actionable path forward for your next pregnancy. Karyotyping is the traditional baseline. As shown in this matrix, it involves looking at cells through a microscope to verify the presence of all 46 books. This method excels at spotting massive structural errors. It can identify if an entire book is missing or if a balanced translocation has occurred, where large sections of two different books have swapped places. The trade-off here is resolution. Karyotyping is affordable because it only scans the covers of the 46 books. It cannot read the individual pages, meaning tiny genetic errors slip through undetected. On the right, we have the modern gold standard, Chromosomal Microarray, or CMA. This technology physically opens the books and scans the text on the DNA level. This scan detects microdeletions and microduplications, tiny missing or extra paragraphs of genetic code that are invisible under microscopes but cause severe developmental issues. Providing this level of detail requires expensive hardware and specialized bioinformatics, which often pushes the cost of a CMA above $1,500. While CMA offers 100 times the resolution of karyotyping, it actually misses the balanced translocations that the cheaper test catches. A higher price tag does not make CMA a complete replacement for karyotyping. While DNA feels like it should be instant, this timeline explains why a CMA takes 2 to 4 weeks. Labs must physically grow fetal cells in a culture and extract the DNA before the scanning process can even begin. These biological phases follow a fixed clock. During the quality control phase, scientists must account for maternal cell contamination. If the mother's DNA mixes with the fetal sample during collection, the final report will be inaccurate. To prevent this, the lab uses STR marker analysis to carefully compare the mother's blood against the sample, ensuring the final genetic data belongs strictly to the fetus. The steep cost and month-long wait reflect the intensity of this quality control. These steps are mandatory to prevent the trauma of a misdiagnosis. When your CMA report finally arrives, the findings will fall into one of the 3 zones on this scorecard. A normal result lands in the green zone, indicating that no significant genetic anomalies were detected at the microarray level. A pathogenic result lands in the red zone. This identifies a known disease-causing microdeletion and provides a clear medical explanation for the clinical situation. A VUS, or variant of uncertain significance, lands in yellow. This means an anomaly was found, but medical science does not yet know if that specific change causes harm. High-resolution testing creates a specific tension. CMA provides deep genetic answers, but it also risks psychological ambiguity when the machine uncovers an anomaly that medical science cannot yet interpret. If you are currently pregnant and assessing the health of a fetus, the choice of technology depends on your goals. NIPT, or non-invasive prenatal testing, is shown here on the left. It requires a simple blood draw to isolate fragments of fetal DNA floating in the mother's bloodstream. NIPT is a screening tool. It is safe, but as the probability dial indicates, it only provides a statistical risk. It cannot provide a definitive confirmation. Amniocentesis, on the right, is a procedure where a needle extracts actual amniotic fluid to collect the baby's cells directly. Because this procedure is invasive, it carries a small risk. However, it allows the lab to run the definitive CMA test on the extracted fluid. Amniocentesis is strictly the physical procedure to collect the sample. The CMA is the laboratory analysis performed on that sample to provide the diagnosis. To avoid wasting time, you must map these tests to your specific scenario. This decision tree provides the logic. Scenario 1. If you are testing the parents after recurrent loss, begin with karyotyping to rule out balanced translocations. Scenario 2. If you are testing fetal tissue after a miscarriage, use a CMA. You need the resolution to find the microdeletions karyotyping will miss. Scenario 3. If you are currently pregnant and want a safe baseline check, use the NIPT screening. Scenario 4. If a pregnancy is high risk or an ultrasound is abnormal, you bypass NIPT and go straight to amniocentesis paired with a CMA. Genetic testing is a heavy investment of both money and emotional energy. Do not simply demand the most expensive test. Demand the specific tool that matches your current phase in the family planning journey.